Coming up in the December 9th issue of JACC, there's actually a pair of papers on TRA-2P, or secondary prevention, and it's the TIMI 50 trial. We're going to talk about the one that is not coronary stent thrombosis, we've already discussed, but there was a paper also that took a look at stroke and prevention of first ischemic stroke. And this is an area where it's been kind of tough. And so I'm talking to Marc Bonaca, who is from Brigham and Women's Hospital, and he is a TIMI investigator. And in this second paper, you're looking at prevention of first ischemic stroke with Vorapaxar. Yes. And this is an approach that goes after what?
Yeah, so I think this is, as you said, this is a tough area, right? Where we have patients who have a history of established ischemic stroke. We know from a series of trials, including the stroke cohort from TRA-2P, that intensive antiplatelet therapy is not necessarily the best thing in terms of net outcomes for patients who have had a history of stroke. There tends to be excess bleeding, there was an excess risk of intracranial hemorrhage, and you don't see a lot of benefit. It's also been shown with dual antiplatelet therapy with ADP receptor blockers like clopidogrel and so on. Now, Vorapaxar reduced major adverse cardiovascular events, and it was approved for use in the United States for patients with a history of MI or symptomatic PAD, but no history of stroke or TIA. And so the purpose of this investigation was twofold. First, if you're a clinician prescribing this for someone with a history of MI, knowing it's contraindicated in patients who have a stroke, what happens if you have a patient that you've administered it to or you prescribed it to and they have a new stroke? Are they at excess risk of harm? Are they going to have intracranial hemorrhage? Are they going to have problems later? The second issue is that Vorapaxar is an interesting agent. It is a PAR1 antagonist. PAR1 is a key receptor on platelets for thrombin-mediated platelet activation. But PAR1 is actually expressed on a lot of tissues. It's expressed quite densely in endothelial cells and smooth muscle cells. And there have been other observations in this cohort that perhaps there are effects in other tissues. For example, there were benefits for late revascularization in the limbs that did not seem to be sort of a platelet-mediated effect necessarily.
What you're reporting here in JACC is kind of surprising. It's also good news, but were you a little surprised to see the results?
Yeah, I think we were surprised. One, from the results we saw that, if a patient has a stroke on Vorapaxar, there was no excess risk of bleeding or death afterwards if the drug was stopped. And then the second thing we saw was there was a robust reduction in ischemic stroke, over 40% reduction, which really looks different than thienopyridines, or at least what you see in trials, MI patients and so on. So that biologically, maybe there is something really different about PAR1 antagonism. I think it's exciting though, because stroke is a very difficult thing to modify, especially when you're out of the atrial fibrillation world, where we know that these novel oral anticoagulants are extremely effective, as well as warfarin for stopping ischemic stroke. But in patients without AFib, stroke is one of the most feared consequences, and we just don't have good therapies in the antithrombotic realm. And so this, I think, this difference is quite important.
So the mechanism you're talking about here, the potential mechanism, because obviously that's not what you're looking at here, you have to kind of hypothesize, but what explains the results?
Yeah, well, certainly we would hypothesize that antiplatelet effect has to have some impact here. We know the drug has potent antiplatelet properties, but when you don't see the same benefit for other antiplatelet agents, so perhaps there are direct effects on the vasculature which might contribute to some of this. And actually, when you look at some of the limb endpoints, like acute limb ischemia, you see the Kaplan-Meier curves look quite similar in terms of the pattern. And so it's hypothesis generating only in terms of what the biology is, but it's very interesting.
Are you going to continue looking at it, trying to tease out what's going on?
Yeah, we have a lot of things that we're going to try to look at, specifically about the subtypes of stroke. Are these small vessel strokes? Are these embolic strokes? We'd also like to look at the bleeding events that happen. What were predictors of bleeding? What are predictors of stroke? And I think these are things that clinicians will look to as they try to decide what are the appropriate patients to receive these therapies. All these antithrombotics are a double-edged sword with reduction in ischemic events, but also increases in bleeding. So we're going to try to provide more information.
So based on what you're reporting in JACC, what's the clinical take-home message?
Well, so I'd say, number one, if you prescribe Vorapaxar for a reduction of major adverse cardiovascular events in someone with a history of MI or symptomatic PAD, and they have a stroke, if you stop the drug at that time, they're at no excess risk of bleeding or death. I think importantly also, one of the benefits that they're receiving is a significant reduction in ischemic stroke, and over the 40% reduction beyond aspirin or aspirin and clopidogrel. And so that there is a robust benefit with regard to ischemic stroke, which isn't seen universally with antiplatelet agents.
Well, it's an exciting paper, and I congratulate you, and it's in the December 9th issue of JACC, as is the other one that we have talked about. So please go there and find the editorial comment that accompanies them also. For Cardiol Source World News, I'm Executive Editor Rick McGuire.